Okay, you can see the slides, yes?
تماما دكتور اتفضل.
Yes, يا تامر.
Okay, so I'm going to address the topic of the use of levothyroxine as a once weekly dose. So does it have a rationale and what are the indications for such use? So I'm starting with the topic of non-adherence. So non-adherence with prescribed medications is an ever-present problem, especially in those who has a chronic illness. Non-adherence increases the likelihood of treatment failure. It poses a significant financial burden on health systems, and it is a source for ongoing frustration for doctors. About non-adherence to levothyroxine in specific, you can see this data coming from retrospective analysis of insurance claims data covering more than 15 years and covering more than 500,000 patients with hypothyroidism. And you may see that after starting levothyroxine in 6 months, 40% of the patients are considered to be non-adherent, and 12 months after initiating levothyroxine, more than 50% of the patients are also considered to be non-adherent, which means that non-adherence to levothyroxine is a very common problem. Up to half of the patients are not adequately adherent to levothyroxine. So what causes this non-adherence specifically in hypothyroid patients? It is actually related to the limitations and inconveniences posed by the levothyroxine. So levothyroxine has to be taken in fasting state. It has to be taken on a daily basis. The patient has to wait for at least 60 minutes until they can have a meal or even have tea or coffee to ensure proper absorption of levothyroxine. They also have to avoid other medications which may interfere with the absorption of levothyroxine, like iron and calcium, for the coming 3 to 4 hours. They also have to, as much as possible, avoid drugs which may interfere with levothyroxine metabolism, like anticonvulsants. All these so-called limitations and inconveniences, they interfere with the daily routine of the patient, which may result in poor compliance and so poor hypothyroid or poor thyroid control. Other causes which may explain patients not complying to levothyroxine. In this very interesting trial, they included 100 patients, hypothyroid patients not achieving TSH target, and 2/3 of the patients reported that they simply forget to take the levothyroxine. 1/3 of the patients, they report lack of understanding that levothyroxine should be continuous and permanently used. Only 3% of the patients reported palpitations as the cause for their inadherence. Just the fear of adverse effects may cause non-adherence to levothyroxine, and for some patients, the absence of symptoms may be the cause for not adhering to levothyroxine. So out of a practice point, so if we consider weekly administration of levothyroxine, once weekly thyroxine, this is going to decrease inconveniences imposed by daily therapy. This is going to decrease interferences with the daily routine of the patient, which may lead to better adherence and consequently better control. However, is once weekly thyroxine supported by physiology? Actually, this practice is supported by two facts. The first fact is that levothyroxine has a very long elimination half-life. So the half-life of endogenous thyroxine is about 7 days. However, for synthetic levothyroxine, it depends upon the thyroid status. So it can reach up to 9 to 10 days for hypothyroid patients, 7 days for euthyroid patients, 3 to 4 days for hyperthyroid patients. Such a prolonged half-life, 7 days in euthyroid, 9 to 10 days in hypothyroid, this supports the notion that we may use levothyroxine on a once weekly basis. The second fact is that our body exhibits what we call autoregulation of T4 to T3 conversion. As mentioned by Professor Jacqueline, levothyroxine is a prohormone which is later converted in the body into the metabolically active T3. As you can see here, T4 can be converted or activated into the active form of thyroid hormone, the T3, or it can be activated into the inactive form of thyroid hormones, which is known as reverse T3. What we mean by autoregulation is that the rate of conversion of T4 to T3 is actually increasing at low T4 levels and decreases at higher T4 levels. And I'm going to show you evidence upon this. So I want you to focus for this trial. This was a trial that included 12 patients. It had a crossover design. In these patients, they tried or they compared the once weekly levothyroxine versus daily levothyroxine. And I want you to focus about this right panel. So you can see here that 2 hours after administering a once weekly levothyroxine dose, the free T4 goes up almost 3 times, 300% increase in the free T4. This is only paralleled by only 25% increase in the free T3 4 hours after the dose, and a much greater increase in the reverse T3, 50% increase also 4 hours after administering the once weekly levothyroxine. So immediately after giving the once weekly levothyroxine, we get tripling of free T4, but only increase in T3 by 25% and a more marked increase in the reverse T3 by 50%. On the left panel, here you can see the status of free T4, free T3, and reverse T3 7 days later after giving the dose, immediately before giving the next weekly dose. So you can see here that free T4 is actually 30% lower compared to dose on daily levothyroxine. Free T3 is only 15% lower compared to those on daily levothyroxine therapy, and reverse T3 is 20% lower compared to those who take the levothyroxine on a daily basis. To summarize what we call autoregulation of T4 to T3 conversion, immediately after injection of weekly levothyroxine, there is preferential conversion of T4 to the metabolically inactive reverse T3. This is to prevent a hyperthyroid state induced by almost tripled T4. On the other hand, by contrast, at the end of the dosing interval, 7 days later, conversion of T4 to the active T3 is increased and conversion of T4 to the inactive reverse T3 is decreased to prevent a hypothyroid state induced by lower T4. So don't fear your patient developing a state of hyperthyroidism. This autoregulation would prevent an excess of T3. So we have a physiological basis to this practice. So in the coming part of the presentation, I'm going to present all the data that we have regarding once weekly thyroxine, regarding the dosing, the outcomes, whether on the short term or the long term, the safety of this practice, whether this is cardiovascular safety or hyperthyroid symptoms, pros and cons of this practice, and final conclusions. So available literature regarding this is these 5 trials. So again, we are going to look first on the right panel. These are 3 trials. They all had patients starting from 12 patients and up to 100 patients. They all had a crossover design, and simply a crossover design means that you randomize some patients to once weekly, and then you randomize the other patients to daily levothyroxine for 6 weeks. And then after 6 weeks, they switch to the other side. And those who started on once weekly, they start daily. And those who started on a daily one, they switch to once weekly. And so in all these trials, they included patients who were hypothyroid, stable on levothyroxine, and achieving the target TSH. On the left panel, we have 2 trials who tried to see the impact of using once weekly levothyroxine on patients who were labeled as treatment-resistant hypothyroidism. The first trial included 23 patients. The second trial included 34 patients. All the patients, they were classified as treatment-resistant hypothyroidism. Here they defined the treatment resistance as daily dose more than 1.6 microgram per kg per day without achieving target. And here they defined the treatment-resistant hypothyroidism as daily dose more than 3 micrograms per kg per day without achieving the TSH target. In these studies, exclusions, the list of exclusions were very long list of exclusions. They have excluded patients with history of cardiac disease. That's to say coronary artery disease, atrial fibrillation, or any other rhythm disorder. Pregnant and lactating women, comorbid illnesses like diabetes and hypertension, And even they have excluded patients taking medications which would interfere with levothyroxine absorption or metabolism. Starting with dosing. In those patients who were previously treated and they were achieving euthyroid status on a stable levothyroxine dose, simply they have given them 7 times the normal daily dose administered once weekly. While for patients who were classified as treatment-resistant hypothyroidism, they have calculated the dose using this factor, 1.7 micrograms per kg per day of thyroxine. This was multiplied by 7, and then it was rounded off to the closest 50 micrograms. In both dosing regimens, the tablets were administered in a powdered form. They would crush the tablets and they would be given in a powdered form. And then every week, the once weekly thyroxine was administered at the same weekday and in the same hour as the first dose under direct supervision in the hospital. And then we go to the outcome. I have shown you 5 studies. In these 5 studies, 4 of the 5 studies, they only tested the once weekly thyroxine under direct medical supervision. Only one of the trials, they have started with 6 weeks of direct medical supervision, and then the study was extended for 2 years later without direct medical supervision. So I'm going to show you first the outcomes in the supervised trials. So in those patients who already achieved the euthyroidism on stable levothyroxine doses, the once weekly thyroxine was found to be as effective as standard daily therapy in maintaining euthyroidism. This was evident in 2 of the trials. However, they have seen that TSH was not significantly different, whether at baseline or 6 weeks after treatment, whether in once weekly dose or daily dose. However, they have noticed that there was a slight decrease in T3 and T4 and an increase in TSH. This was observed just before the next weekly dose. This was statistically significant in 2 studies, and it did not show statistical significance in 1 study. You can see here how TSH changes across the 6 weeks and across the day of administration. So you can see here, this is one of the trials. This is TSH at the start of the first 6 weeks, and then after the crossover, and at the end of the 12 weeks, there was no statistical significance regarding TSH at baseline and after 6 weeks of randomization. Here you can see how TSH behaves on the day of administration of once weekly thyroxine. Immediately before giving the dose, TSH is significantly high, and it continues to be significantly increased until 24 hours from administering the once weekly thyroxine. At this point, 24 hours after administering the once weekly levothyroxine, it becomes not significantly increased. While in the treatment-resistant hypothyroid, in the first trial, they only wanted to see how many of the patients would show a reduction in the TSH. So 4 weeks after starting the once-weekly treatment, 75% achieved a reduction in the TSH. It started with TSH 47, and they ended up with a TSH of 80. In the second trial of treatment-resistant hypothyroidism, according to the target that they used, if the target was a TSH less than 10, actually 77% could achieve this compared to only 40%, and this was significant. And they have concluded that once weekly thyroxine was 5 times more likely to achieve a TSH less than 10. They started with a TSH of 26, and they ended up with a TSH of 8. If the target was a TSH less than 5, then once weekly thyroxine achieved 64% less than 5 compared to only 33% after 6 weeks of treatment. Again, once weekly thyroxine was 4 times more likely to bring TSH to less than 5. So this was the outcome for the supervised 6 weeks. What about the outcome for the unsupervised? So in this trial, they have started with 6 weeks of supervised treatment and then 6 weeks of unsupervised treatment. And among 25 patients who were unsupervised for 6 weeks, 15 patients maintained a TSH of less than 10, which gives a 60% efficacy for once weekly thyroxine. And then the same group were followed up for 25 months. This means 2 years of follow-up. During this 2 years of follow-up, 17 patients continued to be on once weekly therapy. So we may consider this percentage, 74%, as a preference to continuing once weekly thyroxine. The median TSH at the last follow-up was only 3, and the last TSH during once weekly thyroxine therapy below 10 was achieved in 82%. So to summarize the results of this one trial, who were testing once weekly thyroxine in treatment-resistant hypothyroidism. They started with 6 weeks of supervision, and then this was followed by 2 years of no supervision. So you can see here that at the start of the trial, they had markedly elevated TSH in some patients mounting to 100. The target TSH was less than 10. 6 weeks of supervised treatment produced 77% efficacy. 6 weeks of unsupervised once weekly thyroxine produced 60% efficacy, and almost 2 years of unsupervised once weekly thyroxine produced 80% of efficacy. Then what about the safety? I think that the main concern that you are thinking of now is it safe to give 7 times the daily dose at one shot? It would be safe for the patient. So about clinically assessed safety, when they asked the patient about symptoms of hyperthyroidism, either using questionnaires or visual analog scales, and there was no significant difference, whether this is at baseline or 24 hours after the dose. They also used the hyperthyroid symptom scale at baseline, 6 and 12 weeks, and it was applied at baseline as well as 4 hours after the levothyroxine therapy with no significant change. So as regard hyperthyroid symptoms, there was no increase in the rate of hyperthyroid symptoms using once weekly levothyroxine. Then we go for the most commonly asked question. Cardiovascular safety, is this safe for the heart? So you can see here that there was no significant difference regarding the pulse rate and the pulse pressure at 2 hours or 24 hours after administering once weekly thyroxine. Also, Doppler echocardiograms were used. They were used at baseline, 4 hours after levothyroxine dose. This would also repeated at baseline and 6 weeks after the treatment, and there was no significant difference in any of the echocardiographic parameters. They also used the markers of tissue effect with no significant differences regarding 6-hormone binding globulin, gamma-glutamyl transferase, ALT and AST, markers of bone turnover, including osteocalcine and alkaline phosphatase, and lipids, blood lipids, HDL and LDL, they did not differ significantly. Only one trial reported the long-term safety, the trial that used follow-up for 2 years, and for these 25 patients, for these 23 patients who were followed for 2 years, none of the patients reported any incidents of arrhythmias, anxiety, or bone fractures. The pros of this practice, number one, in stable euthyroid patients, it produced similar control with less frequent dosing. While in treatment-resistant hypothyroidism, it resulted in a better control in up to 77% of the patients. In real-world setting, without medical supervision, without hospital visits, preference was 74% and efficacy was 80% after 2 years of follow-up. However, we must remember that this was a limited sample with only 23 patients followed up. One of the trials also reported that with weekly therapy, the quality of life using SF36, this was once weekly thyroxine produced improvement in bodily pain, vitality, mental health, and social functioning. However, we have some cons to this practice. This would need for hospital admission, for proper investigations. This may call for direct supervision. Weekly thyroxine therapy may not be suitable for patients with known ischemic heart disease who would be extra sensitive to the effects of levothyroxine. It is unknown whether levothyroxine on a weekly basis would would be suitable for suppression of TSH for patients who require suppression. And again, weekly treatment could be hazardous if several doses are missed. In conclusion, non-adherence to levothyroxine is common. It occurs up to 50% of the patients within the first year of treatment, and this will lead to poor control. Daily intake and several inconveniences imposed with the daily intake of levothyroxine may be the cause. Once weekly thyroxine is supported by two physiologic facts, the long elimination half-life and the autoregulation of T3 levels. Available evidence shows similar control if you use once weekly thyroxine versus standard daily thyroxine. It shows even better control in treatment-resistant hypothyroidism. This was associated with symptomatic and cardiovascular safety, both in short and long term, and even better quality of life in one of the studies. However, paucity of research and extensive exclusions from the studies may limit the once weekly thyroxine use on a wide scale. A personal opinion, I would strongly recommend once weekly thyroxine in patients who are classified as treatment-resistant hypothyroidism. Thank you for attending and thank you for listening. It was an honor for me.
Thank you, Tamer. It was an elegant presentation. You have some question from the attendees.